Welcome to this explainer. Today, we're diving into a genuinely fascinating new study from Google Research that asks a huge question. What actually happens when artificial intelligence gets unrestricted access to our personal health records? We're going to unpack a breakthrough paper that looks at the architecture of advanced large language models, the rigorous testing they went through, in the frankly dramatic real-world results of feeding complex, deeply personal medical histories straight into an AI. If you've ever wondered how AI could evolve from giving generic advice to being a hyper-personalized medical assistant, well, this is the data that proves it's totally possible. Let's get right into it.
We've all been there, right? You type a symptom into a search engine and suddenly you're staring at advice that either completely doesn't apply to you or worse, absolutely convinces you of the worst-case scenario. It's super frustrating, and as it turns out, it's just a fundamental data problem. The internet doesn't know you, so it just kind of guesses based on billions of other people's searches.
So to get real personalized answers, a human doctor needs your clinical context. They use their years of training to weigh a bunch of complex variables, like your age, past surgeries, current meds, family history. They don't just treat symptoms in a vacuum. And as this new research explores, large language models need that exact same layered context if we ever want them to be truly useful and, critically, safe in the medical space. Without that context, even the smartest AI out there is severely handicapped.
Here's our roadmap for today's explainer. We'll cover the generic health AI problem, designing the PHR experiment, the 3 context levels, measuring sharp results, the key outcomes, and finally, risks and the future. Part 1, the generic health AI problem.
Let's start with the core issue we're trying to solve with medical info on the web. Recent surveys show around a third of U.S. adults have used AI to answer health questions just in the past year. But there is a massive bottleneck. The researchers hit the nail on the head here, stating answer quality suffers due to gaps in understanding of the user's context. Millions are using chatbots for health advice, but without knowing your baseline, the AI just falls back on statistical averages. It's essentially flying blind. It gives us hollow generic advice because it literally cannot tell the difference between a harmless symptom in a healthy 20-year-old and a high-risk warning sign in a 60-year-old with a history of heart disease. It just doesn't know your specific baseline.
Part 2, designing the PHR experiment. So, how do we actually fix this? Let's look at the scientific method Google Research used to test injecting medical records directly into an advanced AI model, specifically Gemini 3.0 Flash. The team wanted to see if giving an AI your personal health record, or PHR, would actually make its answers safer and significantly more helpful. To do this right, they gathered a diverse set of 1945 de-identified real-world personal health records. And these aren't just simple little checklists. We're talking about complex, messy, unstructured chronological clinical notes, thousands of words of doctors' observations, lab results, and discharge summaries that the AI architecture has to somehow parse, organize, and comprehend all at once to form a holistic picture of the patient.
To test the AI against these massive files, they didn't just lob simple questions at it. They curated over 2,200 user queries across 3 escalating levels of complexity. First, short web search queries, like someone just asking, what causes a migraine? Then, conversational chatbot-style questions that need some back-and-forth context. And finally, actual, highly complex questions that real patients ask their healthcare teams during clinic calls. This tested the AI's ability to act like a true medical assistant, handling nuanced, multi-layered concerns.
Now, this is really cool. We're literally looking under the hood at the system prompt architecture here. Notice how explicitly they instructed the model. They told the AI to act with expert clinical knowledge, to answer directly, provide the clinical rationale, the why and how, and to maintain a clear, empathetic tone. By engineering the prompt exactly this way, they're forcing the model to anchor its responses in clinical rationale rather than just scraping the web for generic WebMD-style answers. They're making sure it's behaviorally aligned to act like a thoughtful clinician before it even looks at the patient's data.
Moving on to part 3, the 3 context levels.
To actually prove if injecting these medical records helps, the researchers set up this brilliant Goldilocks comparison. They tested the AI under 3 strict conditions. First, no PHR, meaning the AI is completely blind to the patient's history. Second, basic PHR, where it gets a clean, simple summary of demographics, active conditions, and meds. And third, full PHR, where the AI is fed the massive, unstructured clinical notes, averaging over 10,000 words per patient. This absolutely pushes the limits of the AI's context window. It's testing whether the architecture can successfully connect a tiny detail from page 1 with a brand new symptom reported on page 40.
Part 4. Measuring sharp results. But how do you objectively measure if an AI doctor is giving good advice? It's not like checking a math equation. To solve this, they used the SHARP evaluation framework, which meticulously grades the AI's answers on safety, helpfulness, accuracy, relevance, and personalization. And to make sure this was super rigorous, they didn't just rely on automated systems. They brought in real human clinicians to act as graders. These doctors had full access to the patient's records and really scrutinized the AI's answers to make sure they weren't just polite, but medically sound and hyper-personalized to the individual's exact history.
Which brings us to Part 5, the key outcomes.
Just look at the autorater data here. The leap in performance is frankly staggering. When the AI had no PHR, the mean helpfulness score was a dismal 0.17 out of 1, basically useless. But the second you provide a basic PHR, that score rockets to 0.92. And with a full 10,000-word PHR, it hits 0.95. This proves unequivocally that context is the missing key to unlocking AI in healthcare. Jumping from basically useless to nearly perfect just by providing the record is an absolute breakthrough for how large language models operate in specialized domains.
And when we visualize the sharp readings across all metrics, the clustering is just undeniable. If you look closely at the distribution, the black dots representing the AI without context are scattered all over the place and consistently low. But check out those blue data points for the full PHR condition. They're tightly clustered and consistently pushed way to the right, hitting the highest positive ratings across every single metric, from helpfulness to medical consensus. The architecture didn't just get better at one specific thing. Having that full medical record elevated its performance across literally every dimension of quality care. It gets even better when we look at practical application. Beyond just being generically helpful, the AI's ability to give actionable advice went from an abysmal 0.26 to a perfect 1.00. Plus, its ability to actually motivate the patient increased significantly. It stopped saying generic stuff like, consult a doctor for your back pain, and starts saying, hey, based on your recent physical therapy notes, let's look at modifying these specific exercises to reduce strain on your lower lumbar. That level of precise, contextual actionability, that's what bridges the gap between a basic search engine and a truly functional health assistant. Finally, Part 6, risks and the future. Now, it's not all perfect. As hyped as we should be about this leap forward, we have to maintain our scientific rigor and look exactly at where the model stumbled with these massive files. One major error mode they found was something called temporal disorientation. Imagine reading 10,000 words of someone's medical history over 10 years. The sheer volume sometimes confused the AI about what happened and when. It might mistake a totally resolved surgery from 3 years ago as a current active issue. It's kind of like reading a 400-page mystery novel, but the chapters are completely shuffled. The AI knows the facts, but loses the timeline, which leads to skewed advice. Alongside that temporal disorientation, the model occasionally struggled with rare but meaningful confabulations, basically AI hallucinations. And it sometimes failed to factor in social determinants of health, like the AI might enthusiastically recommend an expensive organic diet or a daily swimming routine to a patient who lives in a food desert and has zero access to a pool. The researchers pointed these specific gaps out because an AI hallucinating a medical fact or completely missing the practical limitations of a patient's life is a highly dangerous problem that has to be systematically engineered out before widespread deployment. But despite those risks, the conclusion of the study is incredibly optimistic. The researchers note that giving an AI this deep, complex context has the potential to fundamentally empower us. It transforms the AI from a generic, often anxiety-inducing search bar into a deeply personalized tool that actually helps individuals understand their own bodies, manage ongoing conditions, and become super proactive partners with their human doctors. Which leaves us with a really critical, thought-provoking question as this technology continues to rapidly evolve. The data is clear, context is king, and injecting your health records into an LLM makes it infinitely more helpful and actionable. But as these context windows get larger and the architecture gets even more advanced, if an AI could perfectly understand your entire medical history, would you trust it to guide your healthcare? Think about it. Thanks for joining me for this explainer, and keep questioning the data.